I'm going to introduce Christopher Carroll, who is the Director of the Division of Policy Innovation within Policy Planning and Innovation at SAMHSA, and he's going to present some of the issues that are going on at SAMHSA. And is someone going to move these slides? I will. You will. Great. Thank you. Go ahead.
Can everybody hear me? Is that loud enough?
Anybody here? Okay, we can hear you fine.
Excellent. Good. Well, I'm pleased to be here, but I would like to convey apologies on behalf of Mary Fleming, who was deeply regretful that she couldn't make it there, but due to an unexpected illness, that prevented her from attending. But she is fine, and she's on her way back to D.C. Secondly, I'd kind of like to apologize for me not being there in person, and I know this is a little bit awkward, but I am pleased to be there virtually. But be patient with me as we try and do the best handoff we can here. Fortunately, this is my book of business. I am now Director of Healthcare Financing and Integration for SAMHSA. And Mary and I did go through the presentation, discussed it at length. So we'll just get started here. Next slide, please. Healthcare integration, it takes partnerships. I, of course, am not Mary Fleming, but we've already discussed that. Let's go to the next slide, please. Today's discussion, we'll go through four buckets of information here: a changing behavioral health landscape, integration in a public health context, some challenges we face from a federal perspective, and SAMHSA's role in leading that change. Next slide, please. First, a changing behavioral health landscape. Next slide, please. Why is this discussion important? Poor health outcomes are often made worse by the interaction between individuals and their social and physical environments. That is true. Determinants of health include policymaking, social factors, health services, individual behavior, and genetics. NIMH is doing substantial work in genetics of mental illness. Studies show that the cost of fragmented healthcare systems and the benefit of healthier integrated systems, those are well documented. It's the interrelationship among these factors that determine an individual and population health and community health as well. Because of this, interventions that target multiple determinants of health are most likely to be effective. Determinants of health reach beyond the boundaries of traditional healthcare and public health sectors. Sectors such as education, housing, transportation, agriculture, and environment can be important allies at the federal level in improving population health. Next slide, please. We continue with why is this discussion important? The economic burden of behavioral health. So the World Economic Forum estimates that by the year 2030, mental illnesses and substance abuse disorders will account for $6 trillion in direct and indirect cost, and 35% of lost economic output due to NCDs, or non-communicable diseases. Our partners at CMS at the service level have found that healthcare costs for persons diagnosed with mental illness and common chronic conditions were 75% higher than those without a mental health diagnosis. So CMS has recognized the high cost of chronic conditions. Medicaid populations, the cost for treatment of Medicaid enrollees with common chronic conditions and co-occurring mental and substance use disorders have cost 2 to 3 times higher than average Medicaid enrollees. Next slide, please. So one of the areas that we often kind of use as an example area is diabetes and behavioral health. So patient responsibility. Patients with diabetes are responsible for 95% of their disease management. So they manage their own chronic conditions in a number of ways through blood sugar monitoring and injections if necessary and medication adherence. But this can lead to increased levels of anxiety, depressive symptoms, and lowered self-esteem. And that can lead to poor disease management and therefore exacerbation of a chronic disease and comorbid diseases. Psychiatric illnesses may be independent risk factors for diabetes, and a recent U.S. study has shown that healthcare costs for people with diabetes and comorbid depression are almost twice as high as those with diabetes alone. And in the UK, in the same field, they have found that individuals with diabetes and comorbid depression were 7 times more likely to take time off work than those with diabetes on its own. So there's, issues of absenteeism and presenteeism and other economic costs associated with comorbid diseases. Next slide, please. What is a healthy community? As defined by the World Health Organization, a healthy city or community is one with safe and affordable housing, accessible transportation systems, work for all who want to work, healthy. It's the utopia there. The premise that health is more than the absence of disease has a long history, and we know that that's true. We can go back to the WHO definition of health in 1964, the Declaration of Alma-Ata in 1978, and even to more current research and initiatives, which include the Surgeon General's report on mental health, the recent IOM reports, and even the previous administration's New Freedom Commission on mental health. The concept and definitions of healthy communities are holistic and transcend service delivery to incorporate and impact all aspects of social determinants of health. Our struggle, I think, at the SAMHSA level, but our challenge that we will accept, is that there's no current definition that we can identify that comprehensively describes behavioral healthy communities or any freestanding initiatives that focus on a community's behavioral health apart from its health. And that's not really what we want to do either, but we do have a behavioral health focus. Many healthy communities initiatives incorporate social and emotional wellness as a component and create interventions to impact this area of health. And most indicators of community health address behavioral health in some fashion, but not directly. Next slide, please. You can't have health without behavioral health. This is something I think we all know, and collectively I think we're making progress on this statement, but let's look further. Next slide, please. What is behavioral health? Well, in the context of health integration, behavioral health means the promotion of mental health resilience and well-being, the treatment of mental and substance use disorders, the support of those who experience and or are in recovery from these conditions, along with their families and communities. So a much more expansive view of behavioral health there. Next slide, please. Primary care behavioral health integration, federal initiatives. Lots going on right now. OASH, which is the HHS Office for the Assistant Secretary for Health, has been working for a number of years on an initiative around multiple chronic conditions. And as a side note, there has been Medicare now is referring back to this research and work that's been done by the multiple chronic conditions work group in OASH. And effective January 1st of 2015, Medicare has it is presenting CPT codes, which will allow physicians the opportunity to manage multiple chronic disease through coding and reimbursement. These are not face-to-face sessions. They are for individuals and their physicians to manage 2 or more chronic conditions. It's only billed once per month. The payment rate of $41.92. Now, that may not seem like much, but a good physician would manage a chronic condition anyway. At least now they are being acknowledged for the work that they're doing and obtaining some reimbursement. SAMHSA has done considerable work in the integration field. I'm sure most of you are familiar with our PBHCI grant program, which is the Primary Behavioral Health Integration Grant Program, and this is it focuses on the physical health of adults with SMI and technical assistance for bidirectional integration. We have a technical assistance center, which has a tremendous amount of resources and has been a great advocate for the program and for integration. We are finding, we've done an evaluation of the program, and we are finding successes, and we are finding areas that we know we need to work on. Interestingly enough, we are finding considerable success in management of hypertension and blood sugars, but less success in obesity rates and smoking, as you could imagine. Within the President's FY15 budget, we have our Primary Care and Addiction Services Integration Program. We're excited about this program. It builds off the success of the PBHCI program. Currently, we have identified that there's a significant overall higher cost of care for those with substance use disorders as an untreated chronic disease. The likelihood that a patient seeking care for substance use disorder will successfully complete a referral to a primary care facility is low in general. I think we all probably understand that. Substance use disorders can cause physical health problems or exacerbate existing physical health problems. For example, cardiovascular conditions are closely related to cocaine use. They include chest pain, syndromes, heart attacks, heart failure, strokes, aortic dissections, and arrhythmias. And alcohol use causes, according to the CDC, causes approximately 80,000 deaths a year. Also, self-medication is an interesting area that we're looking at because the use of a substance to lessen the negative effects of stress, anxiety, and other mental disorders, or other side effects of pharmacopsychotherapy. Self-medication in itself may lead to addiction or other drug or alcohol-related problems. Our partners at HRSA, we'll talk more in-depthly about that in just a little bit. They're doing a lot, and we're encouraging them to do more. They are integrating behavioral health screenings, brief intervention, and treatment into primary care settings. And we are also working with the Million Hearts campaign, which is working to wrap behavioral health services to address the ABCs, which is, if you're not familiar with those, that's appropriate aspirin therapy, blood pressure control, cholesterol management, and smoking cessation. Next slide, please. Integration, federal initiatives. We have heard quite a bit. Integration at the federal level also includes UFEDs getting together and integrating. So we're doing the best we can to organize ourselves across a number of different agencies and sub-agencies. The AHRQ Center for Integration Models, which is the Agency for Healthcare Research and Quality, have been developing models of integrated behavioral care in primary settings. CMMI, which is the Center for Medicare and Medicaid Innovation, is issuing just a lot of money to test models using SAMHSA'S and AHRQ indicators and our technical assistance materials and educational efforts through the Center for Integrated Health Solutions. The ACOs are longstanding and ongoing. Health homes as well. SAMHSA partnered with CMS on the health home finance reform efforts to help them and states design and deliver new models of care. As such, SAMHSA has engaged in over 45 consultations with more than 25 states to promote coordinated integrated care for persons with behavioral health conditions. Next slide, please. Health reform, a changing healthcare environment. Our system is changing, and that is, we owe a debt of gratitude to the passage of the ACA and passage of the MPIA law. We're looking at, according to the Assistant Secretary for Planning and Evaluation, another 60 million plus lives being covered. Medicaid expansion is now up to 28 states. We expect that and hope that that increases, and that's resulting in significant increases in Medicaid and CHIP rolls. Lots going on out there. The system is starting to form, and it's starting to organize itself. Next slide, please. Integration in a public health context. Next slide. Seeing behavioral health as any other public health condition. So behavioral health is fundamental to individual and community health. We have to go beyond being part of healthcare. We have to focus on community prevention and wellness and recovery supports, and behavioral health impact on healthcare costs and outcomes. So we have to, and it is of my opinion that behavioral health can help and in some ways lead the effort to bend the cost curve. And the workforce, as the system grows and as access increases, the workforce is going to need to expand. Preventionists, behavioral health, and other healthcare practitioners and community health service workers. So, as a result, SAMHSA is directing its effort to define the role of behavioral health in the broader public health and healthcare systems, and to improve that service connectivity and financial alignment of health and other social services, so that individuals with behavioral health conditions are better able to access services, receive more highly coordinated care, and improve health outcomes at a high value to cost ratio. So what SAMHSA committed to is to foster the integration between behavioral health care and the public health care system, to include government, private, nonprofit, and faith-based entities providing health, behavioral health, and social services, wide net. We will collaborate on developing a comprehensive strategy to effectively finance behavioral health services and other social services that contribute to the overall health of the individuals and community. What we're looking at there is making sure that payments and financing of systems are not linked to service or volume, that they're linked to quality. So this is a challenge for SAMHSA, and SAMHSA has been primarily a grant-making entity. So as we move to a public health leader that provides policy leadership and regulatory oversight, surveillance, data analysis, public information, and practice improvement, it's a big task for a rather small agency with a very big mission. Next slide, please. Moving beyond primary care focus. So if we had to look at the landscape of healthcare, we might consider primary care, specialty care, emergency care, and rehabilitative services. And then the social supports contributing to health include housing, employment, basic needs, and other issues. Next slide, please. So SAMHSA's role in health integration is to extend beyond health and behavioral health care systems and to recognize that to treat an individual's health and behavioral health needs, we must address their social needs, such as housing, employment, education, and transportation. Our plan currently is to develop this concept and create a framework for action. And this is in my wheelhouse, but not an easy project at all. Next slide, please. Challenges. Next slide. What it's going to do is it's going to require us to create new partnerships. We talked briefly about the workforce, but I think peers specifically are a portion of the workforce that SAMHSA needs to encourage and states need to encourage to use more. The financing of services and systems, we're going to have to do more to create alignments and incentives beyond just disease treatment. So how can we get to healthy people and healthy communities? Messaging, perceptions of seeking treatment. We'll talk about this a little bit later too, but SAMHSA has another initiative called the Science of Changing Social Norms, which I'll go into in just a little bit. And multiple systems, multiple conditions. This, as it relates to the chronicity and acuity of folk that intersect with our systems, this results in high-end cost and multiple treatment arenas that need to be connected. Next slide, please. So SAMHSA will, as it looks to create new partnerships, look outside the normal partnerships. In the workplace, so EAPs, I think we need to start talking about corporate social responsibility and more directly with the private sector. We also need to work, as we said before, with public health, but with specialty services as well, like endocrinology and oncology and cardiology, patient, jails, healthcare system, and injury directors. Now, it took me just a little bit to figure out what an injury director was, but it makes complete sense because these are state-based positions that I believe most states have. And its hub of thinking, I believe, is in the CDC's Injury Center. Injuries kill more than 180,000 people per year, and that's one death every 3 minutes. And these are a result of violence and injuries such as motorcycle crashes, falls, homicides. These are more deaths than cancer, HIV, or the flu combined. The interesting correlation there is alcohol, drugs, and mental illness may have a major influence over these deaths. Next slide, please. Financing. We need to do our work the way people come to us, not the way that money comes to us. Now, we have had some experience in this. We've done some marginal money follows patients demonstrations and cash and counseling demonstrations, but those were really marginal efforts. Right now, most everything is moving towards larger systemic efforts of today. The financial alignment incentives are less about, for me, less about build it and they will come, and it's more about pay for it and they will come. But this also includes, return on investment and building business cases and doing what's best for people rather than money. I think the good news is that state and federal governments are evolving to quality-based purchasing. You don't have to look any further than what you're seeing come out of SAMHSA, CMMI, the HRSA Behavioral Health Expansion Grants. There's a new Medicaid Innovation Accelerator program, which is interesting as well. But we have to do better across a broad array of domains to incentivize change and get better outcomes. Next slide, please. Messaging. This is a tough one. We won't use the word stigma, but negative attitudes lead to social discrimination reduction or reduction of support for prevention and treatment delays in detection and inadequate or no treatment. So in the 2015 presidential budget, we have an initiative we're calling the Science of Changing Social Norms. And this is an effort to develop and test an array of messages and media design messages to improve attitudes, understanding, and behavior of Americans about mental and substance use disorders and the willingness to seek help for them. It's the goal of the initiative to use communication science and market research to identify the most effective and evidence-based methods for decreasing negative attitudes, increasing knowledge, improving willingness to seek help for mental and substance use problems to ensure outreach funds on the initiative are spent where they will make the most impact. So that needs to be done because negative social norms and perceptions still exist. I think we all know this. Majority of Americans recognize that prejudice and discrimination afforded to those suffering from mental illness. Despite this, most Americans, and this is according to a survey by the Kaiser Family Foundation, most Americans indicate they have their own reservations about working with or living next door to someone with serious mental illness. That's around 48% of people are very or somewhat comfortable living next door to someone who has a serious mental illness. So around just under half. Drops dramatically when we start talking about maybe a different or more personal issue. So 66% of parents say they would be very to somewhat uncomfortable if a person with serious mental illness worked in your child's school. So that's, we're still dealing with a lot of misconceptions and a lot of messaging that we need to get out there. Next slide, please. So through our messaging, what we hope to accomplish, we have some goals set out to improve the social acceptance of people with mental and substance use disorders, expand understanding of health, economic, and social impact of untreated mental illness, increase support for behavioral health as a public health priority, increase Americans' willingness to seek help. We have a tremendous amount of work to do here, but the window, I believe, is open on this issue. So we're going to jump through with the science of changing social norms. Next slide, please. Behavioral health workforce shortages. So we didn't have enough people to begin with, and now we have a lot more people coming into the marketplace and into our service systems. You can see the statistics there. 55% of U.S. counties do not have any practicing behavioral health workers. 77% have a severe shortage of mental health workers. 96% report unmet need for mental health prescribers, and a tremendous amount of shortages for psychiatrists and other health practitioners. As our system changes, the workforce demands increase. That's going to require innovation in how we view our workforce and who that workforce really is. And I think the use of peers, both in substance abuse and mental health, are prime examples of untapped resources. So we have a great partner in HRSA, and HRSA is doing a lot of funding right now. On September 12th, HRSA announced that it would be providing $295 million in Affordable Care Act funds to increase primary care at health centers. This included adding professionals, which will add around they estimate 4,750 new jobs to expand primary healthcare services, among other things. That includes reaching an estimated 1.5 million new patients nationwide, which includes 38,000 mental and substance use patients. Also, at the end of July, HRSA also announced that they would be providing around $55 million in Affordable Care Act funding to 221 health centers in 47 states and Puerto Rico to establish or expand behavioral health services for over 450,000 people nationwide. The health centers will use these funds for efforts such as hiring new mental health professionals, adding mental health and substance use disorder health services, and employing integrated models of primary care. So the word is out there, and investments are being made, but there's still considerable challenge ahead of us. Next slide, please. More demand equals more workers. Bi-directional integration between primary and behavioral health care with increasing emphasis on screening and early intervention. This takes a new and different and additional training to have these models deployed. There is an increased need that we need to understand and have the skills to utilize health information technology and EHRs. Valuing a recovery-oriented system and recovery principles. This is certainly an area that SAMHSA will need to work with its partners on. If there has been one area that we can say SAMHSA definitely owns, it is the recovery area, and we know that it works, and we know that people recover, and we know that the domains associated with recovery actually do sustain recovery and promote health. The value of prevention and preventionists, we've got to do, I think we need more preventionists, and they need to be better connected into our public health system. Peers, of course, and credentialing, licensure, and competencies. Next slide, please. SAMHSA's role in leading change. I have already tried to weave in a few of the SAMHSA initiatives and programs through the description today, but we'll talk a little bit more in-depthly here about that. Next slide. SAMHSA moving forward. So we are constructing a white paper that discusses the paradigm shift in the way that we view care from a treatment-only system to one that focuses on population health, public health, community health, healthy communities, wellness. And that includes primary care, specialty care, rehabilitation, and crisis services. Talked a little bit about Million Hearts, but this second bullet here is about the partnerships that we'll need to create. Million Hearts is an interesting kind of multi-layered partnership effort that's got widespread participation and acceptance. So if we had to envision something like a Million Hearts, we were looking at like a million minds. Next slide, please.
And Christopher, we only have a few more minutes.
Last slide. SAMHSA's theory of change, advancing the behavioral health of a nation. So this is really about how SAMHSA sees its programs. So SAMHSA, we have to use our human resources and our financial resources strategically to effectuate change not only in the limited number of states or communities that we can reach with our grants or project funds, but in the nation as in its whole. To that end, it's fundamental to our planning process for SAMHSA to consider how each of our policy initiatives and grant programs work together to advance a policy portfolio. For example, opioid overdose or serious mental illness or workforce development. We've kind of talked about some of those today. Within the context of SAMHSA's broad public health portfolio. So that approach requires SAMHSA to identify desired outcomes for each of its policy portfolios and determine the appropriate number, type, and variety of initiatives and programs within the portfolio to drive solutions and yield the proper outcomes. Equally important is the need for SAMHSA to consider how to leverage successes and learnings from programs and initiatives, best lead by example into further ideas to broader audiences that can advance and sustain implementation. So, SAMHSA is funded and there are a number of programs that are appropriated funds by Congress to do certain things. And we've done a lot of good things for a long time, but we can only reach so many grantees. So if that's our goal, is to reach just 50 grantees in Cleveland and Poughkeepsie and wherever, that's not a bad thing, especially if they're successful and do better for people in those 50 communities. But if we want to advance the behavioral health of the nation, how do we take those learnings from those communities and from those grant programs? And how do we put them on a trajectory from innovation, translation, to dissemination, to implementation, to wide-scale adoption? So if we know, and we evaluate things, we evaluate a lot of things, and continue to do evaluations year after year after year. We are demonstrating the success. Well, let's see if we can talk about success in a broader framework that has sustainability, that makes change for many more people. So that's kind of the theory of change of how we think about our programs as well. So that's the end of my presentation. I don't know how you would like to proceed from here.
I think we will stop there, and I'll just comment that I think the approach that SAMHSA is taking is not a lot different than the approach that we're taking in California. It all sounded very familiar, and I don't think we have anyone in this room who would object to any of the pieces that you just shared. It was very helpful. Thank you.
Yes, and I'll work with Alice. If you have any specific questions from your audience, or if you have any great ideas that you want to send along, I'd be very interested in looking at those and entertaining them, and having conversations with the people that are there today. So, again, we thank you for the opportunity. SAMHSA thanks you. I thank you, and I know Mary thanks you as well.
Okay, thank you very much.